Hearing will come to order. I'd like to welcome everyone to today's hearing entitled A Continued Assessment of Delays in Veterans' Access to Health Care. This hearing marks 2 years since this committee exposed the wait time scandal that has gripped the department since 2014. I'm proud of the work that we have done in those 2 years, particularly digging into the actions of bureaucrats whose self-interest was put ahead of the veterans that they were charged with assisting. The purpose of this hearing is to examine the efforts that VA has taken to improve access to care for veterans and to identify where serious issues still exist. Based on the bipartisan work of this committee, GAO has undertaken an audit of new patient primary care wait times at 6 facilities across the Veteran Health Administration. GAO's review found that veterans at those facilities waited between 22 and 71 days, which is significantly more than the 5-day average that Secretary McDonald has declared to this committee earlier this month. Now, this discrepancy can probably be easily explained. First, VA only tracks and monitors a portion of a veteran's actual wait time when tracking access data. Instead of considering a veteran's wait time to be from the date when the veteran first contacts VA to request an appointment to when the appointment takes place, VA actually considers a veteran's wait time to be from the date when the veteran wants an appointment and the date when the appointment actually occurs. This is problematic because it doesn't take into account the following. It doesn't take into account the time it takes the VA scheduler to contact the veteran to schedule the appointment, the fact that it is a regular practice for schedulers to negotiate a desired date with a veteran, or the fact that outright manipulation of desired dates to zero out wait times is still one of the most prevalent types of data manipulation that occurs within the department today. In effect, VA continues to ignore the main forms of data manipulation while it continues to come to Congress, to this committee, saying there is no data manipulation. To this point, you will not find what you do not seek. The obvious result of VA reporting only a portion of a veteran's actual wait time is artificially low results. I still don't understand how a culture could persist in presenting inaccurate data to this committee, or more importantly, to the veterans of this country. A true picture of wait times, or more importantly, the veteran experience the Secretary speaks about quite frequently, can help us ensure an adequate allocation of the resources that we are asked to provide. But when this committee only hears requests for more manpower, more space, and more flexibility, it's hard to reconcile the additional resources with a reported wait time of only 5 days. This discrepancy between reality and VA claims was captured by GAO in its report, where VA data shows that wait times were at best underestimated by 2.5 times, and at worst, 11 times the full wait time that the veteran experienced. Another tactic that VA uses to make its wait time appears lower is to combine shorter wait times for the large pool of established patients with the longer wait times of the smaller pool of new patients. This dilutes the wait time data, making new patients' waits appear shorter since they have been commingled with data from the other cohort. For years, VA has blamed incorrect appointment scheduling and long wait times on training issues, largely because it was warned about those issues as far back as 2005 when the Inspector General's office published a report highlighting the improper scheduling practices and poor training process. Many OIG and GAO reports since that time have found that the same scheduling problems continue to exist. Yet in the 11 years since VA continues to blame wait time manipulation on the very same cause, a control over which VA has complete control. Secretary McDonald has repeatedly asked that we allow him to run VA like a business. But I can assure you that if an executive running a company used the same excuse to explain away 11 years of problems in a row with no change to show for it, that individual would be out of a job. But not at VA. Despite years of reports of confirming systemic issues, the department has successfully fired just 4 people for wait time manipulation, while letting the bulk of those behind its nationwide delays in care scandal off with no discipline or very weak slaps on the wrist. Another issue regarding accountability is how VA continues to ignore retaliation against the whistleblowers that we have relied on for some of the information that our committee has acted on. The committee has asked VA for all adverse actions where an employee was disciplined for retaliation against a whistleblower. VA provided our committee a list showing that as of March 15th of 2016, only 6 individuals were disciplined for whistleblower retaliation. However, looking deeper at the report, one of the listed employees is Sharon Hellman, who the committee has already shown was not successfully disciplined for whistleblower retaliation, was in fact successfully disciplined for failing to report accepting gifts. 2 of the other disciplined employees were listed as housekeeping aide supervisors, who are clearly not high-level supervisors. That leaves 3 employees. 2 received reprimands and 1 received a less than 14-day suspension. To be clear, according to VA provided documentation, no employee has been removed for whistleblower retaliation. This is representative of the fact that, contrary to public statements by VA senior officials, whistleblower retaliation appears to most certainly be tolerated within the department. So now, 2 years after what was and is a systemic crisis in care being brought to light, it is time for VA to stop using misleading data to tout wait time successes that simply do not show the real wait time experienced by our veterans. I want to hear what concrete actions have been taken, what fundamental changes have been made, and what tangible cultural shifts are occurring within the department. Advertising artificially lowered numbers does nothing to stimulate the change that is needed to improve veterans' access to care. And with that, I yield to the ranking member, Ms. Brown, for any opening remarks that she may have.
Thank you, Mr. Chairman, for calling this hearing today. Following the wait time scandal of Phoenix, Congress passed and President Obama signed the Veterans Access, Choice, and Accountability Act of 2014. In it, we mandated that there be an independent assessment of veterans' health care. The assessment highlights many of the things we hear from our veterans. We hear that VA provides excellent health care, especially health care related to the special needs of our veterans. We also hear that in certain areas, VA is at the forefront of health care in this country. We also hear from our veterans that VA care is often fragmented and that it can be difficult to navigate and arrange non-VA care. We hear of long wait times and limited access. Following the assessment in the Surface Transportation and Veterans Healthcare Choice Improvement Act of 2015, we mandated a report by the VA regarding a plan for how VA could consolidate all purchased care programs into one new Veterans Choice program. We received that report last year, and this committee is currently working with the VA on the best way to implement the legislative requests. The VA is on track to see, listen to this, 6,277,360 unique patients and 9,247,803 unique enrollment. In fiscal 2015, VA completed 56.7 million appointments, nearly 2 million more than fiscal 2014. That is roughly 226 appointments per day. Let me repeat that. That's 226,000 appointments per day. The number of patients that the VA sees would put any other healthcare system to shame. I am pleased that the GAO studied newly enrollment veterans and their access to primary care. In my conversations with veterans, time and time again, they say that once you get into the VA system, the care is the best in the world. Let me repeat that. Once you get into the system, the care is the best in the world. It is this initial appointment that is so hard to get. I am troubled by the GAO finding that nearly half was unable to access primary care because VA medical center staff did not schedule appointments for these veterans in a quick time frame. The GAO report goes on to say that veterans' access to primary care is hindered in part by data weaknesses and by the lack of a comprehensive scheduling policy. We are at a tipping point right now as to what the VA would look like and the services it would provide for veterans in the coming decade. I look forward to hearing from witnesses today as to what this aspect of the VA would look like in the future. With that, Mr. Chairman, I yield back the balance of my time.
Thank you very much, Ms. Brown. As accustomed with this committee, I would ask that all members waive their opening statement to allow me the opportunity to introduce the witnesses at the table today. From VA, we're going to hear from Dr. David Shulkin, the Undersecretary for Health in the Department of Veterans Affairs, and he's accompanied by Dr. Lynch, Assistant Deputy Undersecretary for Health and Clinical Operations. From the Office of Inspector General, we have Mr. Larry Rinkmeyer, Director of OIG's Kansas City Office of Audits and Evaluation. He's accompanied by Mr. Gary Abbey, Acting Assistant Inspector. Finally, we'll hear from Ms. Deborah Draper, Director of the Healthcare Team at the Government Accountability Office. And I would ask if all the witnesses would please stand so we can swear you in. Raise your right hand. Do you solemnly swear under penalty of perjury that the testimony you are about to provide is the truth, the whole truth, and nothing but the truth? Thank you. Please be seated. Let the record reflect that all witnesses did answer in the affirmative. Dr. Shulkin, you are recognized for your opening statement of 5 minutes.
Good morning, Chairman Miller, Ranking Member Brown, members of the committee. As the chairman said, I'm accompanied by my right here by Dr. Thomas Lynch, who's the Assistant Deputy Undersecretary for Clinical Operations, and seated behind me, Dr. Poonam Maleg, who's the Senior Advisor to the Undersecretary. I arrived at VA approximately 9 months ago, and I understood when I came here that this access crisis was a national priority and the status quo simply wasn't acceptable. It's not my objective today to tell you that we fixed all the problems or that we don't have issues. Rather, it's my objective today to tell you that we are focused on this. This is my #1 priority, that this is VHA's #1 priority, and we are going to stick at this till we get this problem resolved. The first thing I did when I arrived as the Undersecretary was to assess all the data on wait times. There were literally file cabinets full of reports and bookshelves filled with data. And I have to tell you, I made it through medical school okay, but I had a really hard time understanding all this data. Very, very confusing. What I didn't see was the ability to clinically prioritize which veterans needed care the first. And I didn't know how to run a healthcare system unless I understood that you needed to see the patients that were sick as the first. So that's the first thing we did. We changed it so we could clinically prioritize the veterans. And that led to 2 national stand-downs where we opened up every VA medical center across the country and saw those veterans who needed the care that day on the day of the stand-down. And that led to real significant sustainable improvements. We had 57,000 urgent consults in what we call level 1 at the first stand-down. Today, it's a 77% reduction. There are 12,000 urgent level 1 consults. On our second stand-down, we addressed 81,000 urgent appointments, and we got 93% of those gone through and resolved. This month, we're launching what we call our Declaration of Independence, which is called the Declaration of Access, which are 9 core principles that are going to fundamentally redesign the way that we provide access to veterans. They include some pretty bold moves like same-day access in primary care and same-day access in mental health. Now, I will tell you, these are aspirational goals to be done by the end of 2016, but I've never been part of a change effort that started with low expectations. And I'm confident we can get these bold goals done because today we have 34 medical centers in the VA system that are currently doing same-day access in primary care. So we can do this. We have to spread these best practices throughout the system. We also have to make the wait times more understandable, Mr. Chairman, as you said, very, very difficult to understand. And I will tell you that my academic studies are in patient safety. I teach my students that there are bad systems, not bad people. And so I've already said we have to change our systems. But when we do identify bad people in the VA and people have lost their ways, not following our values, we will hold them accountable. We have held 29 individuals so far accountable with disciplinary actions on the VA wait crisis. As the chairman said, 4 of them have been fired. We've trained 32,067 schedulers. We've done 11,500 individual visits auditing these schedulers. The Joint Commission has been invited and visited every single one of our medical facilities. We have a new training program for schedulers to launch this spring, beginning in May. But our measurement system's too complex, and where I want to move this to is the veteran experience, asking veterans, are they satisfied with access? And in fact, in every medical center today, we have a system called VetLink. When you come in, you go to a kiosk, you actually are asked whether you're satisfied with the access to care. 89% of veterans today are satisfied with the access to care throughout VAs. And I have all of your individual data, by the way. But we have to do better. We hired 17,000 new employees in the last fiscal year. That's a net number. A 10% increase in productivity through RVUs over the last 2 years. 2.2 million square feet we've added of clinical space. We have a new scheduling system being rolled out now called VSE, a new veterans application that they can schedule themselves. We've allowed direct scheduling in audiology and optometry. We have group practice managers now over all of our medical centers. We're sharing best practices and access across the entire system. And of course, as you know, we're working much closer than ever with our community partners to provide care. 57 million appointments last year, as the ranking member said, 1.6 million more visits last year than the year before, 96% scheduled within 30 days. We're processing claims faster than ever before, 25% increase in claims processed last month. We're looking forward to the comments by the GAO and the IG. I have to tell you, we are not afraid of criticism. We welcome it. We want this type of transparency. In conclusion, I just want to tell you, the VA is making sweeping changes. We are making progress, but there's significant work that lies ahead. That's what I'm here to do. But recall, as the ranking member said, the VA provides excellent care every day. In fact, this year alone, 4 peer-reviewed studies showing our care is equal or superior to what's happening in the private sector. We appreciate the support of all of you on this committee and look forward to answering any questions. Thank you, Mr. Chairman.
Thank you very much, Dr. Shulkin. Mr. Rinkmeyer, you are now recognized for 5 minutes.
Mr. Chairman and members of the subcommittee, thank you for this opportunity to discuss the recent reports that we have issued that have addressed various obstacles to veterans receiving timely access to health care. As you mentioned, I am accompanied by Mr. Gary Abbe, the Deputy Assistant Inspector General for Audits and Evaluations. 2 years ago, VHA's ability to provide veterans timely access to care became an even larger national focus. In 2014, we published 2 reports detailing the serious conditions that existed at the Phoenix healthcare system and provided VA leadership with recommendations for immediate implementation. These reports brought much needed accountability over serious access issues. Since our August 2014 reports, we have initiated a series of audits and reviews evaluating the extent to which veterans receive timely care. We have published several comprehensive reports detailing veterans' experiences during their initial application and their enrollment for health care, VHA's effectiveness in its efforts to improve veterans' access to psychiatrists, and VHA's consult management. In addition, a number of more recent reviews are still in progress, including work which members of Congress requested at the Phoenix healthcare system to evaluate hiring practices of medical support assistants or the schedulers, and continued concerns about timely access to care. The national attention sparked by our reporting on the Phoenix healthcare system resulted in a dramatic increase in the number of contacts to the OIG hotline and the number of inquiries and requests sent to us by members of Congress. A number of these hotline contacts continue to allege inappropriate practices by VHA staff that undermine the integrity and reliability of wait time metrics, as well as allege that VHA's initiatives to provide veterans care in the community are not working. Our audit, reviews, and healthcare inspections have reported challenges VA faces in administering all aspects of purchase care programs, authorizing, scheduling care, documenting the care in the veterans' VA medical records, and timely and accurate payments for care. Two reports we issued in February 2016 highlight some of the problems we see. In our review of alleged untimely care at the Colorado Springs community-based outpatient clinic, we substantiated the allegation that some eligible Colorado Springs veterans did not receive timely care, and non-VA care staff did not add veterans to the Veterans Choice List, or the VCL, in a timely manner, or in some cases not at all. Generally, this occurred because scheduling staff used incorrect dates that made it appear the appointment wait time was less than 30 days, which resulted in the veteran's exclusion from the VCL. In our review of alleged patient scheduling issues at the VA Medical Center in Tampa, we again substantiated that the facility did not add all eligible veterans to the VCL when their scheduled appointment was greater than 30 days, but we also found that staff inappropriately removed veterans from the VCL, and the facility staff did not cancel veterans' existing VA appointments when they did receive an appointment in the community through the Veterans Choice Program, which blocked other veterans from taking that VA appointment. My office recently initiated a pilot project to audit one VISN and its facilities to evaluate three key components of access: data reliability of wait time metrics, access through the Veterans Choice Program, and consult management. Our objective for this pilot is to provide comprehensive and timely oversight at all facilities within a VISN in order to provide the facility directors within that VISN a report detailing their current data and scheduling practices. We hope that by focusing our resources on this issue, we can audit each VISN and its facilities every 3 years, as we currently do with our VBA regional offices. We feel this work is important and will help provide a veteran-centric view of what actions VISN management is taking to ensure situations like Phoenix do not occur in the future. In conclusion, our work has shown that VA faces challenges in providing adequate access to health care. We have a number of active projects involving VHA practices and procedures that ultimately affect veterans' access to the Veterans Choice Program. We will continue to work with VA to provide the independent oversight and objective recommendations to help move these programs and initiatives forward. Mr. Chairman, this concludes my statement. We'd be happy to answer any questions you or members of the committee may have.
Thank you, Mr. Rinkmeyer. Ms. Draper, you're recognized for 5 minutes.
Chairman Miller, Ranking Member Brown, and members of the committee, thank you for the opportunity to be here today to discuss veterans' access to VA health care. My testimony today is based on GAO's ongoing body of work in this area, including most recently a report publicly released yesterday on newly enrolled veterans' access to primary care. I wish that I was here today to discuss better news, but unfortunately that's not the case. Since 2000, and in particular over the past 5 years, we have consistently reported on VA's failure to ensure veterans' timely access to health care. In 2012, we found that outpatient medical appointment wait time data were unreliable, implementation of the scheduling policy was inconsistent across medical facilities, telephone access was problematic, and scheduling resources were not effectively allocated. In 2014, we found that access to outpatient specialty care was problematic due to mismanagement of the consult process, including poor oversight and the lack of clear policies. In 2015, we looked at veterans' access to mental health care and found that the way VA calculates wait times does not always reflect the overall time a veteran is waiting for care, the lack of clear policies precludes effective oversight, and access data may not be comparable over time or between medical facilities. Our most recent work focused on newly enrolled veterans' access to primary care, which is typically the entry point to VA's healthcare system, and critical to ensuring veterans obtain needed medical care, including specialty care. For this work, we found many of the same problems as we have previously reported. We reviewed a sample of 180 newly enrolled veterans' medical records across 6 VA medical centers and found, for example, for the 60 veterans in our review who requested VA contact them to schedule appointments but had not been seen by primary care providers, 17 were not contacted at all because these veterans did not appear on the new enrollee appointment list, which is intended to help track newly enrolled veterans needing appointments. Medical center officials were not aware that this problem was occurring and could not tell us why these veterans did not appear on the list. Further, for 12 of these 60 newly enrolled veterans, medical centers did not follow VA policy for making contact to schedule an appointment, which states that there should be 3 documented attempts by phone, and if unsuccessful, a letter sent. For the 120 veterans who requested care and were seen by primary care providers, we found the average number of days between the initial request that they be contacted to schedule appointments and the dates they were actually seen ranged from 22 to 71 days. About half were seen in less than 30 days. However, veterans' experiences varied widely, with 12 veterans, for example, waiting more than 90 days. Delays in care were due to issues such as appointments not being available when veterans wanted to be seen and medical centers' failure to follow VA's scheduling policy. In this most recent work, we also continue to see data weaknesses due to errors such as schedulers incorrectly changing dates, as well as the lack of a comprehensive scheduling policy, which has created confusion and contributed to the errors seen. In 2015, Veterans Health Care was added to GAO's high-risk list due to VA's problems providing timely access to care, among other reasons. This list identifies government operations that are vulnerable to fraud, waste, abuse, and mismanagement, or in need of major organizational transformation. In designating VA healthcare as high risk, we identified a number of concerns, all of which affect veterans' access to timely health care, and includes, for example, ambiguous policies and inconsistent processes, inadequate oversight and accountability, and poor training. It has now been over a year since the addition of VA healthcare to the high-risk list, and to date, we have seen at best little progress by VA in addressing the issues. We are very concerned about the lack of meaningful progress, and our concern is heightened further because the window of opportunity for making progress under the current administration is rapidly closing, if not already closed. VA healthcare's access problems are significant, persistent, and not only a disservice to our nation's veterans, but places them at risk for harm. The status quo is not appropriate, nor should it be accepted. Mr. Chairman, this concludes my opening remarks. I would be happy to answer any questions.
Thank you very much, Dr. Shulkin. I know that you have been hard at it for 9 months, and a simple question, does it irritate you that even after your 9 months, and we're talking about 2 years from the exposure of the wait time problem, that there still is serious problems and manipulation of wait times?
I am very, very impatient to get this problem resolved, and I am concerned that we have data out there that is not necessarily understandable by people. I am concerned when I hear about mistakes being made, and wherever we do find that there is manipulation of data, that is unacceptable, and we're taking action. And so we're doing everything that we can, but am I impatient? Am I upset about it? Absolutely. And this is why it's our #1 priority, Mr. Chairman.
Expound on the action that you're taking, because it appears, that folks have said for almost a decade that it's been lack of training or improper training. That's 10 years that this has been going on, or more. Give me some concrete steps as to what you're doing, and have you really analyzed what the root cause of this issue is?
Well, let me first start. It's an excellent question and a very fair question. First of all, I want everybody to be clear. We do not have access or wait times in our performance measures. In other words, nobody's getting bonuses. There is no incentive whatsoever to be manipulating this financially as there was in the past. So I think thanks to your committee's work, we make sure that that isn't existing. So I'm going to go back to the fact that in general, we mostly, of our 340,000 employees, have very, very good dedicated employees. We have bad systems in place. One of the things that we've talked to you about is, this is our current scheduling system to the right. It is DOS black screen. To think that this is how we're having our 32,000 schedulers have to schedule appointments invites confusion. It invites the inability to do this accurately. So we are putting in now, currently being rolled out, the one to the left, which looks like a Microsoft Outlook calendar. And that's important that we give our people the right tools. We're also evaluating a commercial system called MASS, which offers greater capabilities. Number three, we are insisting that our leadership do visits to the schedulers personally. And where they find that people aren't scheduling appropriately, they're pulling their scheduling keys. And we're doing that on a regular basis. We are talking about this and trying to do better training. We are taking disciplinary actions where we find that people have deviated. And so we're just going to have to stick at this. I don't know any other faster, magical way to make this happen, and I'm frustrated by it.
I think it would surprise many of the members to know, or maybe it wouldn't. You know, we just saw an example of the scheduling software that's being used $127 million later, and we are just now looking at something that could be purchased off the shelf. A quick question. GAO found that almost 1/3 of the veterans that it reviewed, 17 out of 60, did not get contacted for an appointment because they did not appear on the near list. And one would assume that directors at these facilities neither knew this was occurring, nor they didn't know why a veteran would not appear on the near list. And so the question is, why would a hospital director not know?
Yeah. Well, when you read the GAO report, I think it's pretty clear that we didn't do the best that we could for veterans. So that's why we appreciate the spirit and the information, because it's going to help us do this better. So we are sunsetting the NEAR report. We are moving it towards an automatic system called Welcome My VA, where we're contacting, reaching out to every veteran. Part of the problem that was in the GAO report, they said, is we had the wrong phone numbers for some of these veterans. We couldn't reach them. When we reached some veterans, they didn't want appointments. They wanted CMP exams, so we got them there. Other veterans said, no, thank you. I know I originally said I wanted an appointment, but I no longer want an appointment. So we have to do a better job, but it wasn't that every veteran that Ms. Draper just mentioned, we failed. We failed too many, but a lot of them, frankly, those facilities just weren't able to get in touch with, or when we did, they didn't want the appointments.
Okay, and then my time's expired, but I got one more question that I want to ask you, because a lot of folks have talked about accountability at the table and wanting to hold people accountable for things that they had done. But, you know, in the media, there have been examples, including an employee who participated in an armed robbery, a chief of staff that was improperly prescribing drugs to a VISN director's wife, a nurse who is being charged with manslaughter and the death of a veteran patient. They're all still on the payroll. Similarly, according to the weekly list that VA provides to the committee in the wake of the nationwide wait time manipulation scandal, VA has successfully fired only 4 people for wait time manipulation. How is any of this possible, especially those on the front end who have been, some of them have been convicted of crimes?
Yeah. Seems hard to believe, Mr. Chairman. So let me try to step through my understanding, and if I make any mistakes, I will commit to you that I will get back to you with that. You mentioned the VISN director. He's not on our payroll. He's retired from federal service. It is my understanding that the person who was found with some of the criminal allegations no longer at the VA. The person, one of them actually is going through a court hearing, and we're following the court's procedures on that. But look, somebody who does either violate the law or violate our principles does not belong at the VA, and we clearly take that seriously. We go through a very extensive process of due process to get them there. Sometimes it takes a long time, but we do not want people that shouldn't be treating veterans. And I take that very seriously. So if there are some of those cases that you've talked about that we haven't acted fast enough, we will go back and take a look at them.
You talked about the VISN director having retired. It wasn't the VISN director, it was his wife that was receiving prescription drugs by the chief of staff of that particular hospital. And one other thing, it was something that hit the press a couple of weeks ago, and that was the doctor at Toma that had his medical license suspended for emergency reasons by the state. I believe you took action, fired that individual. Now a court it's been adjudicated that his license should not have been suspended on an emergency basis. So you have had to, I assume, put that person back on the payroll.
No.
Not on the payroll.
Not on the payroll.
Okay.
No, you're correct about the court action, but that does not change our administrative action.
Okay. Is that person appealing at this point your firing of them?
My understanding is they're looking at their options in that regard, yes, sir.
Okay, because my question would be, if that person is brought back on the payroll and subsequently the medical board goes through the normal process of suspending that person's license, how do you get that money back from that individual that comes back on your payroll?
Well, I think we have to let people have their due process, but right now we've made a decision, an administrative decision, not to have them on the payroll, and we are not planning on changing that decision unless there's new information that comes up that we would have to consider.
Okay, thank you very much. Ms. Brown.
Thank you, Mr. Chairman. Mr. Secretary, it just seems like you've been here longer than 9 months. This problem that we're having with the VA goes back more than 10 years. I've been on this committee for 23 years. So we've had problems with the VA over a long period of time, and it would be a misnomer to act like these things just occurred. But what I would like to ask, and I'm very concerned about, is that the GAO report have once again, just a couple of days ago, put VA on the high-risk list. Explain that to me and what we're doing to take care of this problem. I want to get to the stand down, what you all have done and the positive things that you all have done, but please tell me about this because I'm real concerned.
Yes. Well, I believe the VA was placed on the high-risk list probably well over a year ago because it was prior to my confirmation. But the GAO has been very clear about the reasons they put the VA on the high-risk list. We have inconsistent policies and procedures. We have not systematized best practices or the best processes across the VA the way that a healthcare system should. And we have 102 outstanding recommendations, or at least that was when we went on the GAO report. I think we've gotten some of them down, but there's still many outstanding recommendations. We work with the GAO now on a regular basis to show them how we're working to fix that and in consultation with them. But look, the GAO was right in this regard. We had policies and procedures that were conflicting, and we're working to fix that because you can't have that. And the best practices across the system, that's what healthcare systems should be doing. It's why it's one of my 5 priorities, and we are focused on learning from the best and putting it throughout the system. This is going to make VA a better system, and I thank GAO for that. I'm anxious to get off this list fast. I don't agree with Ms. Draper's assessment that we're not making progress. I know we're making progress. It may not be as fast as she wants us to or as fast as I want us to, but we're heading in the right direction and we're addressing the right issues.
The stand downs.
The stand downs are part of it, but the stand downs aren't a way that you sustain improvements. They are the declarations of emergencies. And when you have urgent patients that aren't being seen, they are emergencies, and we have to act like that. But they've led to sustainable improvements, our 9 core principles of how we're going to redesign access in the system. So 10 years from now, A year from now, we're not going to be talking about this in the same way.
And when you all had the stand-downs, how many people showed up in the various areas?
100% of our medical centers were open on those Saturdays, no exceptions. People asked for exceptions, I denied them. So we acted as a system in the country. Thousands of people. Dr. Lynch, do you have a number of how many?
I think we had 5,000 employees that were actually involved in the stand down. There were 10,000 patients or so that were actually seen on the day of the stand down. But make no mistake, the stand down was only a symbol. Everything was going on prior to that stand down. So we were actually evaluating open consults, evaluating pending appointments, scheduling appointments, and assessing patients prior to that. The stand down was actually a way to really bring together the 5 points that are in Dr. Shulkin's priorities. We focused on access, we engaged our employees, we looked to the community for help where we needed it, we engaged best practices from across the networks, and we were working to basically restore trust with our veterans.
I just want to say the next time that you all schedule a stand down, it would be good to let the members know, because we would like to, I know I would like to be at my center on a Saturday when you all are planning.
I know at the last stand down, Congresswoman, I was in Orlando, Florida, and there were members of the congressional staff there. So we welcome your involvement.
And last question, what policies, directives have resulted from the stand downs?
What we've done as a result of the stand down, we sequestered a team of people from the field, not from the central office, who have told us what needs to be done to redesign the system so we don't ever get long wait lists again of veterans who need care urgently. And that led to this Declaration of Access, the 9 core principles that every VA medical center is now signing their name to, committing to these principles to fix access in calendar year 2016 with same-day access in primary care and mental health, eliminating our recall system, which we've been using for veterans for a long time, and in making sure that we're using telehealth and expanded opportunities to improve access.
Thank you, and thank you, Mr. Chairman. I yield back the balance of my.
Thank you very much. There was something I was unaware of just a second ago. You testified, I think, at a subcommittee hearing on Thursday about the commercial scheduling software MAS that you just talked about, and I think your testimony was that it's on a strategic hold at this point. $152 million is what it would cost to do that, and the question is, how in the world could a pilot cost $152 million?
Again, the VSE, the VISTA scheduling enhancement solution that's being rolled out now, total cost of the project $6.4 million. MAS, which we do have a contract for, it's an IDIQ contract, so we can implement this. The next step would be to do a pilot at 3 sites. It would be a 10-month pilot where you have to build the interchanges between VISTA and MAS, and the cost of it's $152 million. The total cost of the national rollout is $600 and something million.
Okay, with that, Mr. Lamborn, you're recognized.
Mr. Secretary, you paint a much too rosy picture. The system is broken. For those of us on this side of the dais, we talk to the people and we listen to the people, and the people in my district are very frustrated and angry that we have all of this dysfunction here in Washington, and more specifically with the bureaucracy that continues to fail our veterans. People want real reform, real change, and not just talking points about how everything is about to be fixed. And I've even been told to my face, well, the problems were already fixed at the beginning of the study, and what the GAO documented was, or the Office of Inspector General documented was after the beginning of the study and everything's okay. We can't have a real conversation if you won't even admit that there's a problem in places like Colorado Springs. And I want to share with you a brief excerpt from a letter I recently received from a constituent who found it impossible to navigate the VA system to get health care. His case is important as an individual, but I think there are thousands like him. He wrote a respectful letter, but he's simply beyond being fed up. Here's a excerpt, quote, "Sir, I speak for myself and thousands of veterans when I tell you enough is enough." He says, stop the tough talk and for once act on the corruption and deceit going on at the clinics. And he's talking about the CBOC in Colorado Springs. He ends up with his letter describing a 14-month runaround with the clinic and says, when will it stop? So when will it stop, Mr. Secretary? Veterans take way too much time to get their care, and they're not being able to really have access to the Veterans Choice Program, which is especially frustrating because that was implemented by Congress to try to stem the tide of some of this dysfunction. So the first question, Mr. Secretary, according to the OIG, in places like Colorado Springs, VA staff did not add some veterans to the choice list or did not add others in a timely manner. What we see clearly is that besides the VA altering the times for VA care, like Phoenix and other places all over the country, it now does the same thing by acting as a gatekeeper for veterans who should have access to choice. Why aren't veterans really being given the opportunity to use the choice program?
Okay. Congressman, if you think I've painted a rosy picture, I failed, because I'm telling you right now, I am acknowledging that we still have significant issues and we have a lot of work to do, and that's why it's my top priority, and I'm not going to rest until we do get this fixed. It's why I came here, and I am focused on it, and you and I sound similar when I'm with my staff, because I'm hearing directly from the veterans just like you. So I'm with you. What I am saying, and maybe this is where you thought I was painting a rosy picture, I know we're headed in the right direction. Where we had 57,000 urgent veterans waiting more than 30 days for care, today that's 12,000. Our electronic wait list for our level 1, our most important clinics, down 32% in the past couple months. Our veterans themselves are telling us on these kiosks, we can't manipulate this data, it's our veterans, that 89% are satisfied with their care. The choice program isn't working for veterans. There's no question. We've told you that, and we need to make this system work better, and that's why we have legislation before you to try to simplify and streamline the care in the community to make this work better. So we have significant problems. I'm hearing the same things you are. We're headed in the right direction, but we are a long way from declaring that we've got this problem solved.
Mr. Secretary, your own metrics from February of this year showed that 29% of veterans received appointments in excess of 30 days. 5% of those waited longer than 120 days. Worst of all, over 2,400 veterans are still waiting on a wait list to receive an appointment, and 708 of those have been waiting longer than 120 days. These metrics made the clinic in my district the 8th worst in the United States. So I know of at least 3 people who have died, and it could have been because of this waiting problem. It could have been directly a result of these delays. So I don't see the VA fixing it. I don't really see them being held accountable. And I just have to agree with the man who wrote the letter to my office, enough is enough. Thank you, Mr. Chairman. I yield back.
Thank you, Mr. Lamborn. Mr. Takano, you're recognized for 5 minutes.
Thank you, Mr. Chairman. Mr. Shulkin, Dr. Shulkin, I'm very concerned that the VHA has been placed on the GAO's high-risk list and that veterans are still struggling to get timely access to care. The VA has undergone significant change in the past year, and it will take continued commitment from those in this room and members on the committee to work together to make sure the VA is functioning the best it can to care for our veterans. But I want to move on to some other questions I have. Dr. Shulkin, in your testimony, you mentioned that one of the VA's top priorities remains legislation to streamline the process for VA to work with outside providers. Now, I'm concerned that the provider agreement legislation this committee considers throws out crucial workplace protections in the name of expediency. I offered an amendment when we marked up the provider agreement bill to ensure that the Office of Federal Contract Compliance Programs retained the authority to enforce workplace non-discrimination protections. The OFCCP is the only federal office that protects LGBT employees from discrimination in the workplace and notably protects veterans from being discriminated against for their veteran status. Your testimony seemed to imply that we can improve provider agreements without undermining workplace protections. Do you agree?
What I agree with is that I know that we desperately need provider agreements to make this program work better for veterans. It's not working well, and we need them desperately to be able to do that. I certainly don't know if there's an unintended consequence that you're talking about, and so I haven't looked at your legislation, but we have no intent of wanting to impose discrimination or to take away protections from people and putting in place provider agreements. What provider agreements do is too many small providers, the doctors and the small practices that are today caring for veterans, can't deal with the federal contracting process. It's way too complex, and they simply drop out, especially our nursing homes and our skilled nursing facilities. So we need provider agreements to be able to do an easy-to-do contract with our providers to care for our veterans. And we certainly have no intent to discriminate against our employees.
I realize there's a need to get these providers on board as quickly as possible. I'm concerned that in this spirit of quickly as possible, that on two counts, the possibility that LGBT people could be discriminated against and our own veterans could be discriminated against, that we need to make sure we balance the desire to bring up providers on, but make sure those provider agreements are not discriminatory.
Yeah, Congressman, I have to tell you, I don't understand the linkage between what a provider agreement does and how it could potentially discriminate, but I will get back to you and have our legislative people help me understand that, because that's not our intent.
Well, thank you. Part of providing timely access to care requires having a sufficient workforce. Leveraging community providers can benefit veterans, but we must be mindful of the fact there are many areas across the country that face health workforce shortages in the private market as well. And that's why I was so supportive of increasing the number of graduate medical school education residencies in the Choice Act. Can you give us a brief update on how that rollout is going?
Well, I think it is one of the most important things that you authorized as part of the Choice Act. We need to train more healthcare professionals. There are actually more medical students now than residency spots, and so the VA expanding these spots is important. You authorized 5,000. To date, we've only implemented more than about 380 of those spots. So we're continuing to work with your academic partners in your districts to look to expand these. There are a couple issues. One is the funding, as you know, goes away with the end of the Choice program. So when an academic center, because we do this in partnership with academic centers, VA doesn't, with the exception of Puerto Rico, run its own GME programs. So we say to our academic partners in California, would you like to expand your psychiatry program? And they say, of course we would, but the funding's going to be eliminated when Choice is sunset. And then they say, well, what happens then? So that's one of the problems we'd like to work with you on.
I think there are members on both sides of the aisle that are interested in working with you on that.
Yes,
and as well as the Medicare cap issue.
Yes, and that's an important issue too, the Medicare cap issue. But we believe this is part of the solution, training more healthcare professionals in areas of need. And I know, for example, in El Paso, we're just working, thanks to the congressman, to work with Texas Tech on the new agreement.
Well, I certainly appreciate my colleagues, Mr. O'Rourke and Ms. Titus, and my colleagues on the other side of the aisle for working together in a bipartisan way to deal with this GME issue.
Yes, thank you.
Dr. Shulkin, there were two pots of money in the Choice, the $10 billion, and then there was $5 billion. So the $5 billion doesn't sunset. The Choice program sunsets, but the $5 billion is there until the $5 billion goes away.
Yeah, my understanding is on the GME program, it has a 5-year length of time that you can use the funding for. If I have a correct understanding of that, that would be good news. So I'll look at that.
So it's your testimony today that part of the reason you can't get more slots is because of the sunset, and that needs to change?
the reason we're not going faster, and we want to desperately go faster, is our academic partners need to agree to do this with us. They're telling us that there are two things in general that are preventing them from going faster. One is the Medicare cap issue. The Medicare cap says that if you go above your number, you can't get additional Medicare reimbursement, direct and indirect graduate medical education funding. Many hospitals, every hospital I've worked for, has been at their cap or above. The second is the length of time that it takes to start a program. When you start a program from ground zero to starting it, it often takes 2 years or so. If your money's going to expire before you graduate your first group of residents, the administrators at those hospitals say, I'm not so sure this is a great deal for us. So those are the two issues I'm hearing. If I have it incorrect about the money running out after 5 years, that would be good news, and
Well,
I will look
if we're
into
just
that.
now talking about setting up the program, somebody's way behind the curve. The other thing is, I would tend to believe that the bigger issue is the Medicare cap issue and the reimbursement rates. But Mr. Bilirakis, you're recognized.
Yeah.
Thank you, Mr. Chairman. I appreciate it. Dr. Shulkin, you mentioned in your testimony about direct scheduling. I want you to elaborate on direct scheduling.
Yes.
That it's available to certain veterans for certain specialties. You mentioned ophthalmology and I believe one
Yes.
more. Elaborate for the benefit of our veterans
Yep.
out there. Who can direct schedule? And why is it only limited to a couple of specialties?
Right, right. The way the VA has done this for a long time is you go through a primary care physician, a gatekeeper. So you have to be able to get an appointment with a primary care doctor just to be authorized to get a consult. I have to tell you, I practice now. I'm a primary care physician in the VA. My first appointment was just to get a pair of shoes. I had to actually approve a consult to get a pair of shoes. It makes no sense. So we've started piloting a program where veterans can now directly schedule, without going through a primary care doctor, in audiology and optometry. It worked terrifically. We're expanding that now across the system. I think that was done in Florida. We're expanding that across the system. And then I want to look at, exactly as you're saying, other specialties, podiatry, social work, nutrition, diet, all sorts of things that, frankly, veterans can make the decisions themselves. They don't need primary care doctors' time to do it.
Very good. Another question has to do with walk-in clinics. How many walk-in clinics are out there where you mentioned about access, same-day access?
Yes.
Is that widespread? Because we do have a walk-in clinic in our outpatient center in Newport Richey, and I think it works very well.
Yeah.
How many walk-in clinics are out there? And how long, what is the average time where a veteran would have to wait to get the same-day access?
Yeah. Actually, where I practice in New York City at the VA, that's where I practice in the walk-in clinic. So we're there. If anybody needs to be seen, we see them that day. Not all of our VAs have walk-in clinics. Of the sample I looked at, for example, of the 6 in the GAO report, 3 had walk-in clinics, 3 didn't. But what many...
Why don't they?
Well, because many, 34, actually have same-day access in their primary care centers. So if you can see your patients through your primary care center, you don't need walk-ins. The other ones do need some type of urgent care visits. We do know that in areas that are challenged, they've actually begun some pilots with commercial urgent care clinics as well, too. So this is part of our declaration of access. Everybody needs to get to same-day access for primary care by the end of 2016. Walk-in clinics are certainly a strategy to get there.
So do veterans who need same-day access, do they all qualify, if they qualify for VA care, to go to a walk-in clinic?
We don't have walk-in clinics in every one of our medical centers.
Well,
but
the ones that do.
yeah,
The centers that do.
The ones that do, I can tell you that if there's a walk-in clinic and they are eligible for VA care, they can walk in and be seen that day, yes.
All right, thank you. Next question, again for Dr. Shulkin. One of the VA's legislative asks is to have flexibility and budget authority to avoid artificial restrictions that impeded delivery of care and benefits to veterans. However, the VA has experienced many issues in which they attribute to lack of training and education. not too long ago, the VA encountered a budget shortfall for the same fiscal year, as you know. The VA did not submit to Congress a formal request for emergency funds until months after the VA had already identified a potential budget shortfall as early as March of that year. This was in part due to the fact that the VA employees were not utilizing the $10 billion appropriated for community care through the Choice Program and utilizing the traditional non-VA care account. The VA's only solution was the potential shutting down of VA medical facilities throughout the country. That's unacceptable. The question is, should Congress allow such flexibility? What assurances do veterans and taxpayers have that employees will be trained this time around properly so that another budget shortfall nor threats of medical facilities being closed does not happen again? So give me some assurances, please.
Yep. Well, Congressman, I think you got it exactly right, which is what we had was we had spent all the money in one checking account, so it got down to zero, and we had lots of money in the other checking account. In order to be able to give veterans care in the community, we had to come and ask you for authorization at the last minute. What we're saying is we don't ever want to do that again. That's not acceptable. It's not the right way to run a system. So we want the flexibility to use care in the community funds to support veterans who get care in the community. That means when we train our people in the system how to use it, we can train them that there's one pot of money and now focus on doing the right thing on veterans instead of following rules for 7 to 8 or 9 different pots of money that frankly are too complex and we've shown doesn't work for veterans. So that's why we really do need this type of legislation and we need your support in getting that passed.
All right. Thank you very much, Mr. I'll yield back. Thank you.
Thank you very much. Dr. Ruiz, you're recognized for 5 minutes.
Thank you, Mr. Chairman, for holding this hearing. The issues that we're discussing are wrong in so many different levels, and I'm going to talk about 3. 1 are your goals, 2 are your data integrity, and 3 is the veteran's experience. So goals are important because it defines your success. It helps you achieve your objectives. Setting a goal of 30 days is arbitrary. There is no clinical data to suggest that's the best practice anywhere in the healthcare literature. And you had mentioned how a term which earlier in the beginning of your presentation about trying to match scheduling with the clinical practice, right? So we know that some illnesses are urgent and emergent, and we need to really take care of them right away, and some others could be scheduled maybe more than 30 days, like your routine colonoscopies that you get once a year, right? So I think that you need to start perhaps changing your premise and getting more towards a clinical approach so that you can take care of your high priorities first and not necessarily rush, take up a spot for your high priorities with things that can be done in a routine basis. The second thing is setting up a goals of urgent care appointments within 30 days, which I recently heard of, is nonsensical. Then why are they urgent if you're going to wait 30 days? Usually an urgent is what you call your walk-ins, or maybe even within 48 days when you want to match your clinical practice with your scheduling goals. The third thing that I'm concerned about in terms of your goals is the use of the word same-day access for all primary care and mental health. You're setting yourself up for more controversy by not clearly defining to the veteran what access is. Is it going into picking up the phone and speaking with a scheduler? Is that what access means? Is it receiving the appropriate care? Is that what access means? So the second part is your data integrity. Now, we use population studies to reduce the chance that errors are done by chance, or so that we can get a statistical significant accounting of whether this is a true problem and whether this is systemic. But the only way that we can really rely on those population studies is if your data is accurate, if your data has integrity, and the GAO is continuing to find faults in the way that you collect data and how you're reporting it. So you can understand why we're still skeptical when you tout the number that 96% of all appointments have been seen within this arbitrary goal of 30 days. The other thing is the way you report data. So you're telling me that by veterans who use VetLink inside the hospitals are telling you that 89% of them rate their access good. Well, you're giving me data with a very high reporting bias. Of course they're going to rate it good because they're already on the inside of the hospital. How about asking those that don't get access, that are not inside the hospital, to tell us what their access is going to look like? So for those of us who know statistics and know methodologies, you know, we are skeptical when you report some of these reports to us that may not be as accurate as possible. And lastly, when we can't rely on population data, when we can't rely on the integrity, then we go by case studies. And case studies, depending on the accuracy and the write-up and the details, is what oftentimes we're left to look at. So let me tell you about a case of a wounded warrior who actually works in my office, who is a hero in my book, who went for his yearly checkup for the VA. He is service-connected disabled, manages well. He's prescribed medication through the VA. After waiting 30 minutes on hold, 30 minutes on hold, the veteran was notified that because he had not had an appointment in over a year, he would have to schedule a new patient appointment, even though he was not a new patient. He agreed to the appointment, asked to schedule that appointment as well. They couldn't fit him in until 134 days later. Again, arbitrary, right? As a result, this veteran elected choice, but they still said you have to come in and do your new patient appointment before you get to your choice appointment. So, one, what does same-day access mean? And two, why do these arbitrary numbers exist in the first place? And three, why do veterans need to have a new patient appointment after a certain amount of time, even though they've been getting prescribed medications, you know, as recent as a month?
Okay. Thank you, and I appreciate your skepticism. I think most doctors and politicians generally are skeptical of data, and I think that's a good thing. So let me very briefly tell you. First of all, you said it absolutely perfectly. The VA needs to clinically prioritize its appointments. It's exactly what I brought into the system. We used to have 31 ways of ordering a consult. Today we have 2. It's either urgent or it's not. There is no 30-day rule for urgent care. I don't know where you got that. That does not exist. Urgent patients have to be seen now. That's why we did the stand-downs. I've never had a patient who has an urgent care need that I wasn't working to get them to be seen right away. That's our goal. Get them seen right away when they have an urgent care problem. So I completely agree, and you said it perfectly. Secondly, same-day access. What does it mean? It means resolving the veteran's needs that day. If they need a prescription refill, they don't have to come in. We can do that on the phone or electronically. If they need to talk about how to understand how to use their treatments, we can do that over the phone or from telehealth. But patients who are sick and need to be seen should be seen that day. That's what we're working to get implemented. So I agree with you. We have to set expectations and explain it in a way quicker than we can do today. The last thing about the veterans' experience, look, the only thing that matters, are we meeting the needs of veterans? The VetLink system that you talked about asks them when they're in the system. You're exactly right. So we have a second survey called CAPS. It's what's used by the industry, the private sector industry too. That asks whether you've been able to get into see your doctors when you need it, both for routine and urgent care. So we compare ourselves to the private sector using CAPS. Internally, we use the VetLink system because that's a point-of-care system. So all of your points are absolutely right, Congressman, and we take them to heart.
Thank you.
Dr. Rowe.
Thank you, Mr. Chairman, and Dr. Shulkin, you know I have great respect for you, and one of the things I don't think I would have said if I were you is that 1 year from now things will be different. I'm not sure they will be. I hope they will be, but I'm not convinced. Just a couple of three quick points I'd like to have your answer on. One is if the VA is doing its job, why did we need a stand down? Why did that need to be done?
Believe me, stand-downs are not the way you run a system. Dr. Rowe, absolutely right. If we have to continue to do stand-downs, something's really wrong. The reason why you do a stand-down is because you've reached an unacceptable situation. And the day I learned, literally the day I learned, we had 57,000 patients who had urgent consults greater than 30 days, I said, there is nothing to do but to declare it an emergency. And that's why 2 weeks from then, we had our first stand-down, because it's unacceptable. But that can't be the way that you run the system. You have to put in sustainable fixes. That's what we're doing now.
And I looked at the number of schedulers you've got. You've got 32,000 schedulers. That's plenty of schedulers, because I did the math right quickly in my head, and they schedule 10 people a day, which shouldn't overwork anybody. That's way past 70 million appointments in a year. So you got that fixed. If the system works, and I would like to have you guys define what an appointment is. And what I finally figured out through all this is, look, the day I called you, if you're my doctor, and I called, that's the day I'd call them to get the appointment. What I would see happening was that you would tell the veteran, well, we don't have an appointment the day you want it, but we've got one 6, would that be okay? When the veteran says that's okay, that's their desired date, according to you guys. Just look, the numbers of what they are, just go ahead and say we don't have it until then, and if it's a problem, if you prioritize, as Dr. Reese said, the sicker patients, then see them early. Why is that hard? Why do we make this so difficult?
No, so Dr. Rowe, a couple things. 32,067 schedulers seems like a lot. The only issue I would add to that is it's got a 25% turnover rate every year, GS5s, and so you're constantly circulating people in and out.
Fast food restaurant sounds like.
Yeah, right. Secondly, seeing the urgent patients first, that's what healthcare systems need to do. That's what doctors do. Absolutely. That was missing from the VA. That's what we're focused on now. I absolutely agree. I think when you talked about how we assign clinically indicated dates, preferred dates, that's what the chairman was talking about when he said there's this negotiation going on. That's where we're confusing people. So look, we need to do better with that. We can't have it be an arbitrary way of assigning appointments. And that's where I think we really need to move towards this veteran experience and seeing if we're meeting the veteran's needs, because you can't manipulate data there, right? That's you're listening to your patients, your customers. The data is what it is, and that's where we need to get to.
Then if everybody's speaking from the same song, singing from the same songbook, then you can make some changes. But you can't. When Ms. Draper comes in with completely different information, we hear from you all. How are we up here on this dais supposed to make any sense out of it? And Ms. Draper, a question to you, what would you be recommending to the VA after your analysis? Because clearly, this is not what the VA is telling us is happening. This investigation that you did.
Yes, in our report, this recent report, we made 3 recommendations to VA. One was because we think the entire period that a veteran, from the time that they first request care to when they actually receive care, that should be monitored, that full amount of time, because there's a lot that can happen between the period a veteran requests care to when that preferred date is set. And there's a lot of time that often passes during that period of time. So we made a recommendation to which VA concurred that whole period of time should be monitored, because the preferred date is really an artificial measure for the veteran. They don't really understand what that means. And so the veteran experience is when they actually request care to when they actually receive it. So that's one. The second piece is that VHA has been without a scheduling policy since 2014. And what they've done, they rescinded the policy. They implemented a scheduling policy in 2010. It was rescinded in 2014 after Phoenix. And the way that they've provided guidance to the field has been through memos. And that's really not the way to do. It's been a really piecemeal effect, and it's really caused, the field will tell us that it's very confusing because they get memos, they don't know what they're supposed to be doing. And So you need a really good policy which sets the stage for also really being able to do effective oversight, because if you don't have a very clear policy or you don't have steps that you should be looking at in the scheduling process, it's really hard to evaluate whether people are doing the right things or not, and we've heard a lot of confusion about that. So those are some of the things, and VA, again, concur with our recommendations. So there's a lot that needs to be done. I would say the other thing related to training is that, I know that they have said that they've trained over 32,000 schedulers. I don't know if they're all schedulers, but people with scheduling keys, which could be other people as well. But, have they evaluated the effectiveness of that training? One of the things that we saw when we went into some facilities, we saw schedulers, the same scheduler, making multiple mistakes. We didn't see intentional manipulation, but the question to me is how effective is that training? Where is the oversight? And maybe there's some people that lack the capability or the skills to be able to do this job, and that needs to be accounted for. So there's just a lot of things that go into this whole process.
Mr. Chairman, I'm going to yield back because I'm over time, but there is one other subject that Mr. Takano brought up that we've discussed in the Docs Caucus, and maybe one of my colleagues will bring it up, is the GME implementation. It may be worth a hearing, because what Dr. Shulkin is saying is correct. We had the VA come over and talk to the entire Docs Caucus, and we walked through that. And I've been walking through that in my local medical center trying to get this done. So I think it would be worthwhile in doing that, because 300, we'd like to get them out there, get these young doctors in these training positions. I'll yield back. Thank you
very much, and we will. Let's go ahead and take care of that, because the issues that you brought up are really the first time that I've heard that, and I think it's something that we need to go ahead and address as quickly as we possibly can. It's an easy fix from a legislative standpoint. Mr. O'Rourke, you're recognized.
Thank you, Mr. Chairman. Secretary Shulkin, shortly after I arrived in Congress in 2013, I noticed a gross discrepancy between what the VA was reporting on wait times in the district that I represent, El Paso, Texas, and what veterans themselves were telling me. In 2014, because we couldn't resolve that based on the data we were given by the VA and the assurances from one of your predecessors, Dr. Petzel, we commissioned a third-party independent survey of El Paso veterans that returned results with a margin of error under 5% that showed that instead of waiting 8 or 9 days for primary or mental health care, veterans were waiting over 70 days, over 80 days for those two respectively. The conclusion I arrived at, and I still insist upon, is that the only way to find out how long veterans are waiting for care is to ask veterans directly. And so we will continue to survey. We surveyed in 2015. We will survey again this year. I'm glad to hear that you agree with Ms. Draper's conclusion that the VA must measure from the date that the veteran first requested help to the day that that appointment was delivered. And for anyone who hasn't read this GAO report, this is illustrated graphically on the first page in a way that anyone can understand. So I have a question about that. When will we receive those numbers, and when will that be standardized as the way that VA measures wait times, so that we don't have preferred wait times with multiple points of potential failure and manipulation, and we just have, you asked for an appointment on this day, you received it on this day? Number one. And number two, you gave a great presentation in October on the way forward for VHA that acknowledges that today we have 43,000 authorized, funded, but unhired positions within the VA. We will never hire all of them. We're going to leverage capacity in the community. We're going to specialize within the VA on what the VA should be doing best. That is something that needs to happen if we're going to resolve the fact that there is more demand than there is capacity within the VA. Where are we on that? So those are my two questions: the standardizing of wait time reporting, and where are we on the October plan that you announced at the end of last year?
Well, Congressman, I've already acknowledged that our systems for measuring wait times are overly complex and very difficult to understand. Where I believe that we need to go is to simplify this by looking at the veteran experience, by asking our veterans, are we meeting the needs of the veterans in the El Paso community? And that's the way that it's done in the private sector. They don't have these complex wait times. Remember, we went out, we asked the Institute on Medicine, we've asked so many consulting companies I can't even imagine, tell us the right way to do this, the way the private sector is doing it, and they've come back and they said there is no standard. So so I think what VA is doing is we're measuring so much right now, and trying to report everything, we're confusing the picture. So we have to get better at this, and we have to simplify it, and we are going to do that. I think what the GAO report is talking about is the new enrollees, and that's where we've concurred that we will measure the full wait time. But I'm not anxious to start redefining wait times and getting even more data and more confusing. I actually want to simplify this. On the issue of what do we need to do to go forward to work with care in the community, we need the legislation to streamline the care in the community. We need the provider agreement legislation passed, because we need to fix this program for veterans, and we do need to work with the private sector. We are committed to that, as well as our federal partners like DOD, the Indian Health Service, federally qualified health centers. So we think we did present a plan. We know that you're looking very hard at that, and we'd appreciate your support.
So on both of these issues, I would love to follow up with you to get written specifics on just when we'll have wait times reported in the way recommended by GAO. And two, I want to know specifically what is on our plate that we have to finish in order to allow you to implement what I thought was a very ambitious proposal to make VA work for every veteran and get to what you described, which is outstanding care, and that should be the ultimate focus. When it comes, for my colleagues, when it comes to measuring wait times, we have introduced a bill, the Ask Veterans Act, which would standardize throughout the country in each of our districts the ability to get objective third-party confirmed wait times, the actual wait times. The VA reports for April of 2016 that veterans are waiting 13 days in my district for primary care, 10 days for mental health care. When I say that at my town halls, I almost get laughed out of the room. When we report back what veterans have told us in the surveys, they all nod their heads. This confirms the experience that they have had. So we welcome the support and collaboration of my colleagues on this, and I thank you for your commitment for making sure that we report more honest wait times for veterans in our communities.
Thank you.
With that, I yield back.
Mr. Huelskamp, you're recognized for 5 minutes.
Thank you, Mr. Chairman. I think key word I've been looking for in my time on here is accountability from the VA employees and leadership. And I want to drill down on a couple situations that I think are pretty striking examples, and perhaps Dr. Shulkin, you can clarify what's occurred here. But apparently, what I understand is the VA in Puerto Rico has refused to fire a medical center employee who was convicted of crimes related to armed robbery, and apparently in comments to the media, a VA spokesman apparently suggested it was okay for employees to participate as long as it was on their free time. Now, I'm sure you don't agree with that. What is the VA doing to take care of this situation in Puerto Rico?
Congressman, I am aware of that situation, and it is my understanding, and you know, I'm very careful. I want to give you accurate information, so if I misspeak on this, I will get back to you by the end of the day, but it is my understanding that that person is not currently working at the VA in San Juan.
Is it on paid leave?
No, that's not my understanding. Again, I will personally make sure that we confirm that with you, but no, that is not my understanding, that they are not an employee of the VA.
Okay, I look forward to that. Second one, VA apparently, as I understand it, still has not disciplined the chief of staff at the Cincinnati VA Medical Center who was found to improperly prescribed controlled substances. What's the status of that particular employee at the VA?
That situation I'm a little bit closer to. If you will recall, I made an administrative decision to suspend their clinical privileges of the chief of staff, and she was actually in an acting chief of staff role, and also to remove her from that role. She is following her due process, which means that the medical staff is looking at the clinical privileges, and there's a due process going on the administrative decision I made. So there was both a administrative and clinical decision. But currently, she's certainly not in that role, and and
I
she is not.
appreciate the
Yep.
the follow-up on that. So no access to veterans as it stands today? No
she's-
access?
She's not in a clinical role, not in that leadership role, no.
Okay, and what role is she in?
My understanding is she's doing administrative reviews, like quality reviews.
And has been found improperly prescribed controlled substances and is still doing quality reviews?
We had concerns, that's why we took actions. We invited the Inspector General. That was my first request to come in to take a look at this. I know that the DEA has also come in to take a look at this. We are waiting for their final reports on this before we can make a additional determination about that.
And thirdly, going back 2 years, and I'm looking at a statement from Mr. Sloan Gibson. It's in June 5th of 2014, and here's the statement. In Phoenix, we initiated the process to remove senior leaders. And as I understand today, a number of those senior leaders are either still on paid leave or have not been removed or still working through the process, in particular the Chief of Staff, Darren Daring. Is that the case, that it's taken 2 years and Mr. Gibson has yet to fulfill that process and in that process to remove these folks that were covering up secret waiting lists that harmed up to 20 veterans?
Yeah. I believe approximately 30 days ago, Mr. Gibson did make a disciplinary decision on all 3 individuals. That decision was removal. They are each in their own process of due process. Dr. Deering is a Title 38 employee, so he has a shorter period of time in which to do that. The other 2 are Title V employees, which, as we know, we've talked about as part of the Accountability Act, takes a little bit longer.
Yeah, and about the time. So as I understand, that's what I thought situation. So June 5th of 2014, the promise is made public, CNN, we're going to take care of this. As we sit here today, April 19th, still not completed the process to take care of someone and get them out of harming our veterans. You know, Mr. Shulkin, I would ask you to pass on to your superiors, and I appreciate the work you're doing. We've got a VA Accountability Act to take care of this. For some reason, the Senate's still sitting on it. They're talking about spending more money instead of taking care of these folks. This is absolutely outrageous, whether it's Puerto Rico, Cincinnati, or Phoenix. Still almost 2 years later, and we can't get rid of the folks that have harmed our veterans. And just like Mr. O'Rourke, I go in town halls and say, we've got a VA Accountability Act, and they're really working for us, and they all laugh. They've lost all respect within the veterans community. And so we hear these numbers, and I appreciate, and I didn't get a time to ask questions because I'm going over, but I understand, you know, we had 58 cases referred to the Department of Justice for possible criminal charges. That would be my fault from the committee if we could find out what the response has been for the Justice Department to those 58 criminal cases and the disposition of those. So with that, Mr. Chairman, I appreciate letting me go over a few seconds. I yield back.
Thank you. Ms. Brownlee, you're recognized.
Thank you, Mr. Chairman. Secretary Shulkin, I appreciate your testimony today to say that your intention in your testimony, both written and your earlier testimony, was not to paint, you know, an extraordinarily positive picture, but to say that it paints a picture that we're on track. So I appreciate that. I have to say, though, in your testimony, when you quote that in April 1st, 30%, or the wait time for VA overall is completed 96% of the time within 30 days overall, and that's data, I think, from February. When I was reading your testimony last night, I said to myself, oh, gee, it must be my district that's causing the 4% that's not there. So I went back to look at the data, and as of April 1st, almost 30% of our veterans that I represent in the Oxnard CBOC in Ventura County have primary care appointments pending over 30 days. And actually, I asked my staff for the data this morning, and I think based on the data and that one metric, we are the second highest CBOC in the country, with Dover, Tennessee being the highest at 48 days for a pending appointment within 30 days. So we have a problem, and we've had a problem, and I am extraordinarily excited that the VA Greater Los Angeles healthcare system has finally hired a medical center director who is permanent. We have had interims now for a year and a half to 2 years. I've sort of lost count. But we are working very, very closely with Ann Brown, who is, I believe, is doing a very good job and is very aware of what is going on in Oxnard. And clearly, we have had trouble hiring and keeping teams there within the CBOC. I think we have a contracted out facility that plays a role. The choice program is not really working too terribly much in our district, so that's not as large an option as that we would like it to be. So, so we know these things are happening. I guess, you know, my question is that if I wasn't watching this closely, my question is the VA watching this closely, and would you have, nobody brought it to my attention, I just bring it to your attention. And so my concern is, you know, is the VA looking specifically at regional problems that is skewing your data, perhaps, to really address these pockets within the country that aren't doing very well at all?
Yeah. Yes, we are tracking this, and I think you have it correct, which is that this is very different depending upon the geography of the country that you're in. So that we have some VAs that actually don't have backlogs at all, and others, like in your district, that have significant backlogs in primary care. And so we are paying attention to that. We're actually focused on those top 10 to 15%. We're sending our Veterans Engineering Resource Center teams out now to work with those most distressed facilities to help them redesign their systems. We're focused on recruitment in areas that really are struggling with recruitment. And so we absolutely are focused on that. But I think that it's a relatively new direction for us to focus on those areas that have been that really are struggling the way that yours is.
So when did you start working, you know, with, teamed up with the Oxnard facility to help facilitate some of the issues?
Well, I think you identified it correctly in your district. You need permanent leadership in place, and you need experienced leadership. Ann Brown, which of course, as you know, came from Jesse Brown in Chicago, is one of those experienced leaders. We knew Greater Los Angeles was one of the most challenged facilities, so we brought an experienced leader there, and I think you're seeing that makes a big difference. But without having permanent experienced leadership in place, it's very hard to address this in a system as large as we are.
All right, but I can rest assured that the Washington team is working directly with Ann Brown to help facilitate this issue in Oxnard.
I've recently been out there to visit with Ann, and the secretary, some people think he lives in Los Angeles. He goes there so often. So,
well, and I just want to, you know, say publicly that I believe that Ann is working very, very hard on this, and I appreciate her leadership, and she's now giving my district office regular updates. But it is an eyesore compared to, you know, the rest of the country, and needs that attention. So, Ms. Draper talked about, or you spoke actually, Mr. Shulkin, about working directly with the GAO now in a team to recognize where some of these improvements have come from. And I guess I just would ask Ms. Draper, you know, to ask you your feedback in terms of, are those meetings productive, and are you meeting on a regular basis with specific agendas? Yeah, so there are 5 criteria for removal from the high-risk list. One is leadership commitment, one is capacity, and that's having the necessary resources, people and otherwise. A third piece is the action plan. Fourth is monitoring, and then the fifth is demonstrated progress. So what's happened thus far is that VA provided us a draft action plan in January, and it really addressed one of the 5 areas, and we felt that the action plan was not sufficient. So we met with them, provided them comments, and then we referred them to an agency where we felt has done a really good job making progress on their high-risk status. So they have gotten that action plan, and we have committed to VA that we will begin meeting with them starting the end of this month, and then monthly. I think they are trying to get it on target to get us an action plan, a reliable or feasible action plan by August. And that includes having metrics that we both can agree to, that there's progress made. The first plan did not include that, so there's a lot of work to be done, and I think that we are going to work with them to provide feedback. It's a little difficult for us because we have to straddle the line of independence, but we can provide them feedback and direct them to other agencies where we feel have made good progress on the high risk.
Thank you. I apologize for going over. I yield back.
That's all right. Dr. Abraham, you're recognized.
Thank you, Mr. Chairman. Like Dr. Rowe, Dr. Shulkin, my respect for you personally is great, and I know in my heart of hearts you want to get this right. My concern is, like Ranking Member Brown said, this is way before your time. It goes back 10 years plus. So, you know, my concern is the culture of the VA. This may be a bridge too far to actually fix this problem within the VA system itself, and you know, it may be time to look outwardly to a private sector to just do simply the scheduling. If 89% of the veterans are satisfied with their care once they get there, we certainly want to enhance your ability to treat those veterans with the expert care that we know the VA gives our veterans population. But we're talking today mostly about the scheduling issue, where either VA has the inability or the lack of resolve to actually get rid of these poor scheduling employees, and it's certainly in the private sector they can fire at will and they're gone, and they replace them with somebody that does. And your turnover rate, you said 25%. You know, that's hard to keep any quality employee on task, on target with that going on. And certainly with the $152 million and extrapolate to the $600 million to implement the software program, you dangle that carrot in front of private enterprise, they're going to be knocking your door down to do this. And you know there are businesses that do this for a living. That's all they do is schedule patients. So again, just a thought, and maybe a pilot program or something could be on the agenda, just to compare how the private sector does on just the scheduling. I'm not talking about health care for the veteran, but just the scheduling the veteran to get the appointment and you know, compare it against the VA's track record. So again, just a thought. Mr. Rinkmeyer, a couple of questions to you. You said that you guys are hopefully go to each visit every 3 years, and you look at data reliability, the Veterans Choice Program implementation, and the consult management, if I remember the three tagged right. And I guess the first question on the data reliability that you guys are getting from the VA, because the old adage, garbage in, garbage out, if you don't get the data that you need, and if you don't trust the data that you get, then it's hard to make informed decisions. So the question is, are you satisfied, are you comfortable to date with the data that you're receiving from the VA on this issue of scheduling?
No, we continue to see the data is unreliable, which is one of the reasons why we're going to try to implement this VISN approach. National reviews are great, where we sample so many facilities and you know, throughout the country, but we think if we can push this down to a more local level and feed this information to the VISN management and give them an opportunity to take control of their VISN and make changes, we think that's going to be more helpful. But the 96% and the data that has been discussed today, we don't see it. I mean, every facility we go to, it's not accurate.
Okay, and my next question to you too, and it's got a quote, so I want to make sure I get it right. It says in a February 25th, 2016 letter to the President of the Office of Special Counsel, said that the VA OIG investigations of whistleblower disclosures regarding wait times in Hines, Illinois, and Shreveport, Louisiana, which is in my state, were inadequate. OCS found that, quote, the OIG investigations found evidence to support the allegations that employees were using separate spreadsheets outside of the VA's electronic scheduling and patient record systems. However, the OIG largely limited its review to determine whether the separate spreadsheets were, quote, again, secret, unquote. Please explain why the OIG limited its review.
So that review was conducted by our investigative staff, so I was not directly involved with that. I am aware of the concerns, and I know Ms. Halliday, my boss, has made sure that we try not to interpret the allegations too strictly. And, you know, I can ask the Office of Investigations to get back to you on their response.
Well, I guess my follow-up question, were there any criminal charges that were sent up to the DOJ for prosecution that you know of?
So I would say, no, I don't know. I know that there were some, and there's been discussions, but that's outside of our office.
Okay. All right. Thank you, Mr. Chairman. I'll go back.
Thanks. Mr. Zeldin, you're recognized.
Thank you, Mr. Chairman. Dr. Shulkin, April 7th, USA Today story starts with supervisors instructed employees to falsify patient wait times at Veterans Affairs medical facilities in at least 7 states. Was that accurate?
I've reviewed 72 IG reports. 11 of them were found to have intentional manipulation. So that would be accurate, but it's not representative of the majority of their findings.
And of these supervisors, how many of them have been fired?
We have, for a total of all of those IG reports, when I add up going across that, we have 29 individuals that have been disciplined. I think the Chairman Miller before had said 4 have been fired. I'm aware of 5 who retired under investigation. So rather than letting the investigation go forward, they decided to retire from federal service.
When you referenced the number of 29 disciplined, that is from this USA Today story of the...
From the 72 IG reports that I've reviewed. I sort of, I manually counted them up as we went through each of the accountability actions.
Have any supervisors who instructed employees to falsify patient wait times, have any not been disciplined?
Oh, I suspect that of people investigated, there were many more than 29, probably lots more that were investigated, and the evidence did not suggest that there was discipline that needed to be imposed.
Okay, but are you saying that there were supervisors who instructed employees to falsify patient wait times who have not been disciplined?
Of the investigations that we've done that found that found intentional manipulation, we then would send in our Office of Accountability Review to do these investigations. Everybody that was found to have a action or found to have a behavior that required disciplinary action, we have imposed or they have retired.
So no one has not been disciplined?
Oh, I wouldn't say that.
We're going in circles right now. I'm asking about the people who, of the supervisors who instructed employees to falsify patient wait times, have any not been disciplined?
I don't know what your denominator is. Anybody that has been accused of a manipulation, we have investigated. When we have found that there's evidence that they did do the manipulation, we have implemented disciplinary action.
None of those people haven't been disciplined?
I am not aware of anybody that we found that was supervising a manipulation that we haven't implemented disciplinary action. Now, sometimes after the action, they've appealed and those actions have been overturned.
But no supervisor who you have investigated who has instructed employees to falsify patient wait times has not been disciplined.
Congressman, I feel like I'm being asked some questions about. You have to ask me individuals. You'd have to say.
I'm asking about anyone.
Well, look.
Has anyone not been disciplined?
These disciplinary actions have been going on well before I got here. All the information I have, and this is not my responsibility to implement these disciplinary actions. We have an Office of Accountability Review. What I'm telling you is that when I've reviewed these reports, when I find that other people have taken disciplinary actions against 29 individuals, I'm sure there are many more that have been accused of supervising. So I don't know how to answer your question.
Right. Okay. Well, I mean, it's a simple question. There was a USA Today story that said supervisors instructed employees to falsify patient wait times in at least 7 states. You're then saying that you investigate it, and if you have evidence to back that up, then the person is disciplined. I'm asking if through that process has anyone not been disciplined, and then we start going around in circles. We're talking about patient wait times while we're here. We have issues with patient advocates, where I have constituents who will call a patient advocate. They won't get someone on the phone to leave a message sometimes. Many times they won't get a call back. Reports about calling a suicide hotline and getting a voicemail, in some cases not getting a call back. A backlog of appeals this committee is concerned about. Greatly concerning numbers, the Denver VA Hospital construction project. I have a constituent, John Mitchell, in the aid and attendance case with over 20 years of service, an Army Ranger in Vietnam with over 16 years in service of special ops. He suffers from traumatic brain injury that's directly connected to his service. One was from an accident in a military vehicle. Another one was from a parachute fall. And because the VA lost his file, he is being denied his benefits. 20-year veteran, Vietnam veteran, special ops, and he is unable to take care of himself. And we're getting all of these different cases, but the only time that it comes to light for this committee is when the committee brings it up to the VA. The VA needs to be bringing these issues up to the committee beforehand. When one example after another doesn't come to light until this committee brings it to light, or the USA Today does, or an Inspector General or GAO, if it's not initiated by the Department of Veterans Affairs, it looks like a cover-up. So you say that someone who violates the law or violates our principles doesn't belong at the VA. Well, I would argue that that goes straight up to the top of people who are violating the principles of the VA. And it's greatly concerning that it's this committee responsible, and it's the GAO responsible, and it's the Inspector General, and it's the media all responsible for bringing this to light, and you don't do that for us. I yield back.
Thank you. Mr. Kaufman, you're recognized.
Thank you, Mr. Chairman. Just a question about the appointment wait time scandal, because I think that we're getting kind of different summaries of it, if you will. And so wasn't the, you said that it wasn't about cash bonuses, but you didn't put a date on that. I guess that the policy had changed. But what was the policy in 2013 when this issue came to light?
Congressman, I wasn't here then, but I believe that there was wait times as part of people's performance evaluations. And so, Dr. Lynch, am I correct in that?
Yes.
So there was a potential of a financial bonus if people hit certain criteria.
Sure.
Today, that doesn't exist. There is nobody.
So you allowed, people were allowed to retire who were under investigation, who were complicit in manipulating appointment wait times. Is that correct? I think.
I think I said the investigation didn't conclude. Before the investigation was able to conclude, they retired from federal service.
So, but this involves fraud, and fraud is a criminal issue. How many criminal referrals occurred of people who were involved in this scandal?
My understanding, I don't know whether the Inspector General can help us with this, was that we did ask, I think this was actually Senator Blumenthal who asked that the Department of Justice come in to take a look at this, and they ended up declining on looking at most of these cases. But I know that there are referrals that go from the IG to the criminal division.
Could someone comment on that?
There are referrals, and I know in every case where we suspect something, we will make that referral. I can tell you, and this is not my area of expertise, but I think a lot of the money that you're referring to, the bonuses, while inappropriate, is not necessarily a high dollar amount, and there's not a lot of attraction.
So fraud is okay if it's a low dollar amount? Is that what we're saying here today?
Not for me, but I'm just saying.
Really?
The Department of Justice, I think there's not a lot of traction if it's a small
Well, that's
dollar.
disappointing under this administration that would occur. Let me state what is current law, and that is if somebody commits fraud but is awarded a bonus, there is no clawback provision in current law. Is that not correct? Who can answer that?
I'm not aware of the answer to
There is no provision, and in fact, there is legislation before the Congress, and the position of the VA is neutral on that, which I find is appalling as a taxpayer and as a veteran, that when somebody gets a bonus that they clearly did not earn, should not have been given, that the only provision in which the VA is allowed to claw it back is if it is given administratively to the wrong person. But if it's given to the person that is the subject matter of the bonus, even if they didn't earn it, there is no provision for clawback. That law needs to change, and the Secretary needs to take a position affirmative for that legislation and not simply sit on the sidelines. This is about cleaning up the VA. And the Secretary was giving a speech in Denver last weekend, well, I think it's 2 weekends ago, that I was at, where he said that the fundamental problem in terms of the appointment wait time scandal was a lack of training of VA personnel. Is that correct? Was it due to a lack of training?
I think what the Secretary most likely meant was that our system was complex and we weren't spending enough time training. But I don't think he would say that was the only factor. There were many factors involved in this.
It really had nothing to do with a lack of training. It had everything to do with people that were fairly skilled at manipulating the system, because what in fact they did was to make the numbers look smaller to get these cash awards, is that they pushed veterans out on these secret waiting lists who did not get health care. And in fact, there were veterans who died on those secret waiting lists. And you know, I don't know how we ever clean up problems in the VA if we really don't acknowledge their existence. And I really don't believe that the leadership of the VA has acknowledged the depth of the problems that exist here, and that's why they will never be cleaned up under current leadership. I yield back, Mr.
Mr. Bost, you're recognized.
Thank you, Mr. Chairman. Mr. Schilling, I have to ask specifically, in the individual VA medical facilities, administrators and/or directors basically have the ability to monitor this with their own facilities, correct? So make sure they're the ones that are in charge of doing that. Is that correct?
Monitor this wait time?
This wait time
Yes,
and all
sir.
of these. They're the ones
Yes,
that do
sir.
that. Okay, the concern that I have, and I'm going to express this, and I'm going to tell you about a bill that we're working on that you may be aware of. The problem is, I see right now, St. Louis is one of our facilities. In the last 34 months, every 120 days or 280 days, depending on, or 240 days, by your rule, we keep circulating directors in and out. I ran business for years, and if in 120 days, I couldn't get all of my employees' names down. I definitely couldn't figure out where the problems were. And whenever, I thought this was only in the St. Louis facility, but our research has found out that there's 40 facilities that are actually in interim directors that are just kind of cycling through like this. It's very hard to have oversight if someone isn't there for a long period of time and they understand that's their job. Is there anything being done right now to try to cure those problems?
Yes. First of all, I couldn't agree more. You can't solve the problems of the VA unless you have the right leaders in place, and they need to be permanent leaders. So we're on the same page. St. Louis, very unfortunate. We actually had named a permanent leader who was coming
no longer available.
Yeah, he was coming from Hawaii, and because of personal issues, he retired from federal service. And so now we're back in a national search, and we have some candidates. So I am very focused on getting a leader in St. Louis. But I don't count 40, I count 34. That's 34 too many. And so we have national recruitments out in place. It's one of the reasons why we've asked again for your support for Title 38 legislation, because we need not only accountability in the VA, but we also need market rates that will help us attract the very best who will come to take these jobs. Right now, there aren't enough people who want to come and take these jobs.
Because of salary?
I think that the bad press that VA has been getting, our applications are down 78% from the date of the crisis. These are known to be very, very tough jobs, and the salary is not anywhere near what the market rates are for these jobs.
Yeah, I'm pretty sure that nobody wants to jump on a ship that's sinking, and that's the problem, or maybe needs to be sealed up and then bailed out in the condition that it is right now. And I think this is a possible, this just causes a downward spiral, and I think it needs to be cured. Now, I'm willing to work with you on that, and understand the legislation we're going to be pushing forward gives the Secretary about 120 days to look over proposals on what it is that we can do and move forward to try to cure these problems. With that, Mr. Chairman, I yield back.
Thank you.
Thank you, Mr. Bost. I'm going to yield myself 5 minutes to ask a few questions. Dr. Shulkin, as you know, we've been aware of this problem with the training and the procedures for these schedulers since 2005 when the Inspector General first reported on it, and it's been 11 years since then. And then the Inspector General stated in its August 14 Phoenix report, since July 2005, Inspector General has published 20 oversight reports on VA patient wait times and access to care, and that the VA has been resistant to change. I guess my question is about the procedure for responding to and dealing with Office of Inspector General reports, okay? This is something that I've been working on for years in my position here. Is someone actually put in charge of responding to a specific Inspector General report?
Yes. I did not do, when I came into office, a major reorganization of VA leadership because I wanted us focused on this problem, fixing the wait time crisis, not internal politics. But the one thing I did do was I established a new Deputy Undersecretary for Organizational Excellence, whose position it is to focus on this. That's Dr. Carolyn Clancy.
Does one person then have
Yes, one office,
to
one
deal
person.
with this? So
Yes.
then that person will be held responsible for making sure that the Inspector General reported deficiency is corrected?
Well, I will be held responsible, and the Secretary ultimately is held responsible.
Yeah, but it's difficult because,
yes.
you know, we've had so many Inspector General reports where the VA secretaries agreed with the report and agreed to change it.
Yes.
The way things are going, but nothing's changed in 20, 30 years.
So
you realize that, right? I mean,
I do realize this.
report, for example, I'll give you a good example, identified the fact there's no central hiring process for physicians at the VA. That was reported, I think, 8 times over 30 years. That problem still exists.
Yeah.
So no one seems to have fixed that problem. So I want to have where one person is responsible for responding to the Inspector General report. Let me ask Mr. Reichenmeyer, has there ever been an accountable employee assigned to fix a problem in your history with the Inspector General?
So there's always someone assigned, but quite honestly, and I was involved with one of the first 2005 report, and we reported it, and until 2014, there was really no priority placed to it. We reported it in 2005, we reported it in 2007, the right words were said, actions were, changes were made, but when we came back, 2 years later, we found that nothing had been put in place.
Right, well, that's my experience as well. They say, we're going to fix it, but then nobody is actually responsible. A name of an individual whose job it is to actually make it happen never seems to get fixed. Do you think that legislation mandating that the VA assign a specific accountable employee to fix a problem would be an effective strategy?
I think Dr. Shulkin was right that ultimately he's responsible and the Secretary. We make our recommendations generally to the Undersecretary of Health. Assigning, I wouldn't think legislation would be necessary, but that's certainly
I know,
something
but that's
to
what I
be
mean by saying that, there was this problem for 30 years with the IG telling the VA they need to have a central plan for hiring physicians. They said that to the VA 6 times over 30 years. The VA has agreed with them 6 times over 30 years, and yet nobody was ever assigned to fix that problem, and it still occurs today that there is no real central plan for hiring physicians within the VA. So, I mean, you see what I'm talking about, Dr. Shulkin? Yeah. You know, this is something that's a procedural, the way things are done. I mean, it's given to some committee, it's given to some department, but then there's nobody actually who's in charge other than you, and then you say, well, you know, we're all working on it.
But Dr. Benchik, what I'm saying is that is the organizational change I made. I have a brand-new deputy undersecretary whose job it is to do that, and they've put together the Office of Medical Inspector, all of the compliance officers, the regulatory officers, the
What's
ethics
his name?
people. Well, Dr. Carolyn Clancy, you know Dr. Clancy.
Okay, okay.
Yep.
So then, how many Inspector General reports has he looked at so far in that position?
They've been keeping us pretty busy this year. We've looked at least 72 on the wait times alone, and you've probably sent over a bunch of others on top of that.
Well,
So I would say probably over 100.
I would like to see the Inspector General reports that he has looked at and what exactly he has done to respond to those Inspector General reports.
Absolutely.
All right, thank you. I'm out of time, and I think everybody's asked their questions, so we're just about ready for the closing.
Yeah.
Ms. Brown has a closing statement she'd like to.
Yeah, but before, I want to ask Ms. Draper a question. You mentioned the scheduler and that perhaps they're not getting adequate training. We all know that a scheduler is an entry-level job. Do you think that the VA needs to do more to upgrade? Because once a person is trained in that position, if they see another opening, they want to move up.
Yeah, let me just back up a little bit, because I think training is an issue, but I think it's much more complicated than that. I think there's oversight. The VISTA scheduling system is really prone to user error. There's a lot of things that factor into the errors that we've seen. As far as the schedulers, it is an entry-level position. It's generally GS 4, 5, 6. And in previous work that we've done, we heard from facilities that it's a very high turnover position. I think it's the number 1 or 2 clinical position within VHA that turns over each year. And so there's not really a good career path for those individuals. And what we've heard is when someone demonstrates a high level of capability, they're often scooped up and moved someplace else.
Right.
So there hasn't been, I think at one point a couple of years ago, they had instituted in some places a GS6, so there was a career path. And my understanding that has no longer, that doesn't exist any longer. So I do think, I mean, if you put this much responsibility, it's a lot of pressure and responsibility on these individuals that, you know, it is important that they have the, you know, the support and the training and, you know, the oversight. Because as I said in my opening remarks, if someone continues to do the same errors, where's the oversight for that? And what happens when that continues to happen? Because that is what we've seen. So it raises the question about oversight and, you know, quite frankly, whether some of these people are really able to do the jobs that they're put into position for.
Thank you. Mr. Secretary, last thing, you know, I've gone to the medical schools in the Orlando area with the Secretary, and I didn't know that there was some problems with it, because I know we need additional slots. So I'm hoping that you all will get back with us, and if there's something that we on our side need to do, I know we want to do it because we need those additional physicians, and of course, if they train and have those residents, they will probably stay in the area.
Yes, we'd welcome further discussion on that.
And in closing, I'm hoping that the veterans that's listening to what we're doing today understand that we are seeing over 2 million additional veterans in 2015 than 2014, over 226 appointments per day. So if veterans need to come to the system, don't be dumbed down by what you hear and hear. Go and get assistance. Go to your member's office, go to the VA. And with that, you know, we all need to soldier up and make sure that the veterans are being taken care of. Thank you, and I yield back the balance of my time.
Thanks to the entire panel for being here. You're now excused. Today we've had a chance to hear about the many ongoing problems related to veterans access. I guess we're going to have the chairman give a closing statement. Or
No closing statement. I just confirmed with the Caribbean healthcare system that the individual that we were discussing is still on the payroll.
Thank you for correcting that.
So
told you that-
again, the
yep.
question is,
Yep.
why in the world would somebody who's been convicted of armed robbery still be working at the Department of Veterans Affairs?
Okay, well, hard for me to answer that right now. So
Okay.
I think we owe you an answer.
Please, thank you. Thank you. All right. Thank you, Mr. Chairman. We've had a chance to hear about many of the ongoing problems related to veterans' access to health care that continue to occur today over 2 years since the wait time scandal. As we've discussed, the VA has not taken the aggressive steps needed to improve access to care for veterans. Until the VA stops using the excuse of poor training to explain away systemic wait time manipulation, begins holding itself accountable, nothing will change. Dr. Shulkin, it seems to me that the I Care and My VA Access Declaration are just words. These ideas speak to an intent, but to this committee and to veterans, results are what counts. Slogans and rhetoric designed to deflect blame are not good substitute for action-oriented results. Until VA addresses the issues we've discussed today, beginning with accountability, our veterans will have to hope the VA gets itself squared away, but as we know, hope is not a plan. I ask unanimous consent that all members have 5 legislative days to revise and extend their remarks and to include extraneous material. And without objection, so ordered. I'd also like to once again thank all the witnesses and the audience members for joining us today. And with that, hearing is adjourned.